Rapamycin is very good for sports performance because it's very good for age-associated decline in cardiac function. In other words, you see runners after sort of like 30, or like if you're looking at Olympic runners, having a progressive decline from like world records like just about 2 hours to like 3 hours to like 6 hours. This is characteristic of like everything with the heart. All animals with the heart have an age-associated decline in heart function. Rapamycin is real good for that. That's what sort of like the studies that like Matt Cable was doing in dogs. He was showing that in healthy older dogs, rapamycin was improving their heart function. And he could show that in the echocardiogram. And on mice, they could show exactly how it was happening. It was related to a change in kind of like fuel. It's like there was a shift in what the mitochondria was burning. They were burning like in older people low-grade fuel, and in younger people they were burning more like a high-octane fuel. And rapamycin was sort of like shifting that back to sort of like the kind of high-grade fuel they were burning in younger people, and like they mapped the entire protein picture, and they could see that the proteins involved in mitochondria were the things that were changing. People who are sort of like very attuned to that, like cyclists, frequently notice that on rapamycin, all of a sudden, they have better cardiac performance. They can cycle faster, their maximum heart rate is better, their cycling speed is better. So it improves athletic performance.
Hey guys, welcome back. So today's show with Alan Green is brought to you by Myoscience Nutrition. As you can tell, we're talking a lot about aging and natural ways to help to optimize your body's aging response. A natural product that you may want to consider when it comes to supporting metabolic health as you age is berberine fasting accelerator. A lot of people don't really recognize the power of berberine. It's one of the most effective natural products to help support and optimize metabolic health. You can see some of the reviews over at myoscience.com and the berberine fasting accelerator product. There's well over 100 reviews, and people are finding this to be very effective at helping, especially to curb cravings in the evening. You know that late night eating is not conducive to optimal aging or metabolic health. So if you're susceptible or prone, like me, here's my hand is up, for having, say, ice cream or treats or craving some of these foods, you may want to consider taking 2 to 3 capsules of the berberine fasting accelerator. It has a great way and a unique ability to induce the fasting response by increasing ketones and helping to support overall metabolic health. Again, you can check out the reviews. Don't believe me, just go there and see what some people are saying. They're finding that it's very helpful, especially in the evening time, to help to optimize fasting physiology and support metabolic health with age. So the URL to check that out is myoscience.com, myoscience.com. That's myoscience with an X, the berberine fasting accelerator. You can use the coupon code to save. That is podcast over at myoscience.com. Now, in today's show with Alan, it's a phenomenal episode. He spends a lot of time talking about how we age, why we age, and the various ways that low-dose rapamycin, which is actually a drug used in higher dosages to help to prevent the rejection of a transplant, for example, like a kidney transplant or an organ transplant or some sort of tissue transplant. So in supraphysiologic doses, rapamycin is used as an immune suppressant. In lower dosages, rapamycin can and has been shown to be helpful to help support aging by decreasing mTOR. Now, we don't want to chronically decrease mTOR, periodically decrease mTOR, especially in individuals who have an ApoE4 genotype. That's what we talk about today, the context and the subtype of people that might benefit most from considering low-dose rapamycin treatment. So I really encourage you to listen to this and check out the show notes. It was a phenomenal discussion. Alan is definitely in a league of its own when it comes to clinical medicine and translating bench to bedside, looking at what the clinical studies are showing with regards to the benefits of low-dose rapamycin treatment and translating that into a patient population. It's a really phenomenal discussion in Long Island, New York. I hope you enjoy it. Let's cut back to it with Alan Green.
Well, Dr. Alan Green, it's so great to be with you. I called you about a year ago and we planned this conversation, and you know, I've been a huge fan of your clinical work for quite some time, and it seems that in the last several years, folks on the internet and preventative medicine-based doctors are talking a lot more about sort of microdosing rapamycin, which is a drug you're familiar with. What was it that inspired you to get into this medicine in 2016?
Oh, okay. Basically, to make a long story short, I sort of like realized that I was sort of like dying. But I didn't realize, but I was right about one thing and wrong about the other thing. I thought I was dying, but I thought I was dying of sort of like aging. But I didn't really know anything about aging at that time. My knowledge of aging at that time was absolutely zero. But I was aware of the fact that I was deteriorating very quickly, and I was in my early 70s, and I just say, well, this must be aging. However, at the rate of decline that you're going, you're not going to be living very long. You better study something about aging.
Yeah.
Well, it turned out I was completely wrong. I wasn't suffering from aging at all. I was suffering from a congenital inherited cardiomyopathy, the same sort of thing that had killed my mother and killed my grandmother and so forth and like that. I was suffering from that. But when I started to study rap, so I started studying rapamycin, and I decided, well, let me try this. It worked remarkably good. It's like I had the totally wrong idea of what I was treating, but it didn't make any difference. Rapamycin worked very, very good for the symptoms. Now I figured, well, this is incredible. I'm like reversing aging. It turned out that I was sort of like treating a cardiomyopathy. The problem was, and like, rapamycin works very, very good if you treat preclinical disease before you have any symptoms. The time I was supposed to start taking this was 10 years before I even knew I had any symptoms.
Yeah.
So that was the right time to taking it. So at the time I started taking it, it had the effect of stopping the heart disease process, improving the symptoms, but not correcting the like anatomic structural damage. So that's the sort of like thing about sort of like like treatment. It's very good to treat diseases before you have irreversible structural damage in the preclinical stage, before you know you have the disease.
Very important point.
That's why in sort of like my studies in my patients, I do all sorts of stuff to indicate preclinical disease that what they might have, like with people who are like testing everybody to see if they're ApoE type. Mm-hmm. It turns out that 25% of people are ApoE4 positive. That 25% gets the great majority of cases of dementia prior to age 80. However, their problem is a deterioration of the cerebral microvascular system, basically the 250,000 miles of capillaries in your brain. That is like in E4 people, because of that deteriorates. Rapamycin stops that from deteriorating. Rapamycin sort of like stops them from developing dementia. It sort of like stops their entire sort of like risk. So that's sort of like a great example of like finding out a simple genetic test if you're E4 positive or not, and something like 23andMe, and like starting 10 years before you might get any symptoms. It's also I try to like measure everybody's insulin resistance. If people are insulin resistant, it's going to accelerate your age-related diseases. Or if you have high iron levels, I mentioned ferritin is going to accelerate. So I like to look for things that would indicate diseases in the stages before it's caused structural damage. Treating things early.
I love that. That's beautiful, Alan. And if you don't mind me asking, how old are you now?
79. I'll be 80 in February.
Congrats. That's amazing. You know, the average life expectancy in the U.S. has dropped recently. I've heard, and the average American is on, the average Medicare eligible American is on some 5 some odd medications. So people are not taking your advice and getting out in front of this early.
A number one issue is Americans are frequently 50 pounds overweight. Now, if you look at somebody's weight, a typical sort of like man might be 150 pounds when they're 25 years old. That's a great weight. Everybody at 25 years old is usually at their perfect weight. However, the idea has gotten it because like mTOR makes people put on weight as you get older. So it's not the people's fault. It's like mTOR makes people put on weight when you get older. So like people are sort of like putting on weight when they get older, and it's like perfectly acceptable to be 50 pounds more than you were when you were sort of like in like 50 pounds more, or like even if you're like 80 pounds more, you're really 50 pounds more because you've lost a whole bunch of muscle mass. So people who I tend to frequently, in other words, your waistline, and the best indication of that is your waistline. When you were like 25 years old, you had a 32-inch waistline. Now you have a 38-inch waistline. If you use the tape measure, you might be wearing the same, like not your pants, but you might be able to be what, but if you use the tape measure, you have a 38 or 40-inch waistline compared to the 32-inch waistline you had when you were 25 years old. Mm-hmm. That causes generally insulin resistance, and the insulin resistance makes you sort of like much more prone to accelerated deterioration. But people who are sort of like healthy and have good, like can take rapamycin, can do extraordinarily well. I just had like a couple of days ago talked to one of my 75-year-old patients. He was feeling so fit. He took a big expedition to the Andes. He spent 2 weeks climbing like the Andes Mountains, which are like the most rugged mountains in the world. Like other people are sort of like, like talked to another couple, they're like 88 and 93, and they were saying they were doing the same. They were patients of mine for 5 years. They were saying they were doing the same. They hadn't noticed any decline. So people on rapamycin can do very well, especially if they're sort of like real fit and not overweight and a right sort of like weight. But yeah, like the problem is, it's like they're just people, in other words, the medicine isn't treating end-stage disease. The medical model is you don't, in other words, there's no money in keeping somebody healthy. If people stayed healthy, the medical profession would go out of business. It's like, well, like, 50% of like all the nursing homes, all the like, it'd be decimated if people didn't get sick. Mm-hmm. In other words, they're sort of like, like diabetes is like type 2 diabetes is a great example. The emphasis is not to have you lose the extra 40 pounds, become insulin sensitive, not have diabetes, be perfectly fine. The emphasis is you have all the diabetes medicines. Mm-hmm. That's the sort of like, so the emphasis is not to sort of like, doing that. Although that's sort of like working with the drugs they have. Right? In other words, rapamycin has a much better effect on these type of things. It has a much better effect on sort of like, it has a good effect on treating disease, but it's a much, much better effect on treating preclinical disease and stopping the diseases.
Yeah, it's amazing. And so you've had 1,100 patients over the years on rapamycin. I guess maybe for people that aren't familiar with how the drug works and so forth, what is rapamycin doing in the body?
Yeah, so basically, my whole practice is essentially rapamycin medicine. So like the practice is, if mTOR, like I'm treating things that rapamycin is the best sort of like treatment for, and there isn't any other treatment. Rapamycin does one thing, it's anti-mTOR. That's the only thing it's doing. So, understanding what rapamycin does is it's a matter of understanding what mTOR does. It's simply anti-mTOR. mTOR, for some reason, seems to get involved in all the age-related diseases. But the other sort of biggest thing I sort of like in my light treatment is simply aging. Now, aging, I always describe as the most misunderstood disease in all of medicine. But aging, to start off, is not a disease at all. That part of aging, they got right. And that basically, they got that right. Like the ancient Romans got that right. Basically, they said, a disease is something that some people get. If everybody gets something, it's not a disease. It's a natural thing. Aging is a natural thing. The problem is, just because something is natural doesn't mean you can't treat it if you don't like it. And for people that I see, most of the usual complaint is aging, getting older. Nobody wants to hear, well, that's natural. What do you want me to do about it? That's not what they want to hear. They don't like it. The people don't like it. In other words, it's like, I feel good, I'm healthy now, I don't want to be declining. And so that's the sort of idea of that blocking aging. And then the other part about aging is we don't even have the right words for it in the English language, in that aging is synonymous with deterioration. But that definitely doesn't have to how things have to be. In other words, you have aging and you have deterioration. I mean, like an example is, you could look at a B-52, built in the 1950s, well maintained. It's as good now as it was when it came off the assembly line. It's sort of like 70 years old, but it's still the same level. So, but this sort of difference, in other words, that people can't concept the idea of aging is just synonymous and humans with deterioration. They start to think of somebody who's a certain age with that, but that's basically unique to terrestrial mammals. It's not characteristic of other animals. If you look at, say, a 100-year-old crocodile, a 100-year-old crocodile is not deteriorating. A 100-year-old crocodile is a very strong, vigorous, dominant animal, big, strong, dominating the breeding pool. It hasn't deteriorated, even though it's 100 years old. So you have that, it's sort of and you can have that with fish. You can have a 150-year-old fish dominating the breeding pool. So it turns out that aging was an innovation that mammals developed. That was the point about aging. Now, the sort of the problem with understanding, the problem with aging, and it's very, very important to understand aging, and that's the sort of main thing I treat. Aging was sort of off to a good, with Darwin, 1858, Origin of the Species, Natural Selection, Darwin had a very good start with understanding aging. The point was, traits were selected because they were beneficial. If something wasn't beneficial, it couldn't be selected. The problem was, about the 1920s, at the time of a lot of real bad science, time of the sort of Scopes monkey trial, bad understanding of sort of evolution, they came up with the idea that Aging couldn't be controlled by, aging couldn't evolve because of the idea that in order for something to evolve, it had to be good. If something wasn't good, like the basic concept of sort of like evolutionary theory, if something isn't sort of like good, you can't evolve genes to have that thing. That's just how the system works. It'd be impossible to evolve genes that control something if that was not a good thing, not converting a benefit. Now, the people who thought about aging, they were probably old men. They didn't see anything good about aging. They probably should have asked a 10-year-old. A 10-year-old would have told them, aging's really good. All these old people are going to die, and I'm going to inherit the world. So, but getting back to what I said about like the B-52, you can see the same sort of like thing with sort of like if you think of like a stealth bomber. Like the suppose you didn't have enough, you couldn't maintain both of them. Well, a stealth bomber, it's not that it's sort of like new, it's that it has innovations. So, in other words, if you couldn't maintain both sets of planes, you didn't have enough money to do that, you'd have to get rid of your sort of like B-52s so you could have the stealth bombers, not because the B-52s were old, but because they didn't have the new innovations. That's the sort of like idea of aging. Aging is sort of like promotes evolution. It promotes evolution. It's sort of like a mathematical like model. They can demonstrate with computer programs how aging, it's not aging that the point is. The important thing is killing off the old animals. And you're not killing off the old animals because they've deteriorated. You want to kill off the old animals because they don't have the new innovations. Like in a company, you want to fire older employees to bring in new employees that have new ideas. Mm-hmm. That's the sort of like idea. Well, in evolution, the new ideas are new genes. So you could figure from an evolutionary point of view, it's set up that they don't copy things exactly. There's all sorts of variations coming in. Some variations are bad. Those animals die. Some variations are good. But then what you needed was a way to promote the new variations. And it turned out that the way to promote the new variations was to eliminate the old animals that did not have those new variations, so that over the course of 1 million years, you'd be promoting the development of new variations instead of sort of like them not being, and you can see this process of intentional sort of like killing off older animals is not going on in like crocodiles. But crocodiles haven't changed in 250 million years. So, and then now the sort of like practical sort of like application of how all this sort of like took place was, if you go back, say, 180 million years, now you have the fish, they're doing fine. They don't need to evolve at all. They're just like, the ocean isn't changing, they're perfectly happy with how they're doing. You have the sort of like dinosaurs, the reptiles, they're perfectly happy with how they're doing. You have the mammals. The mammals have a problem. They're completely dominated by the dinosaurs. So you could think of a kind of like convention of like mammal inventors. Right? They're getting together and discussing what are we going to do? We can't deal with these dinosaurs. And the idea is like, well, we'll have to come up with new traits. We'll have to be smarter, faster, better eyesight, better hearing, better senses of smell. We want to be like warm-blooded so we can stay up at night and like develop all sorts of innovations. We'll sort of like, have it sort of like the young, we'll sort of like, we'll feed them with like breast milk so they can like grow up. We'll sort of like, we'll do all these innovations. Well, and it's like, I say like, well, good, that sounds great, but how are we going to do that? It's like, okay, we're going to do it by having a short lifespan. You'll have the animals, they'll grow up, they'll breed fast, they'll have 3 or 4 generations, then they'll die, then they'll sort of like, so like, we'll be able to introduce all these new variations real fast and speed up the evolutionary process. So you can see that with sort of like mice or cats and all the generations they could like produce. And sort of like, that sort of like promotes like, you know, evolution of new traits. But you just overrun the place if you didn't have the old animals dying. So you had to have the old animals dying to make room for the new animals, with the idea that the new animals would have new variations that might help. Now, when sort of like, originally when the people came up with the idea that they said the old animals were dying to make rid of the new animals, but that's because they thought the old animals were old. So that was just circular reasoning. They didn't realize it was important to get rid of the old animals because they didn't have the new genetic variations that you would want to promote. But this idea of sort of like programmed death is sort of like a big idea in this sort of like animal world. I mean, you can see it with, say, an octopus. An octopus just is very, very, very good at surviving. They could sort of like, but what they do is, after the female octopus like lays all her eggs, she's programmed to stop eating. She starves herself to death. She dies as the new octopus is being born. So she's being eliminated, and that's sort of like, so she's not competing with the little octopuses. I don't know whether you know it, but like, all octopus look the same.
Yeah.
You'd be able to, you know, should they be saying the whole area, but basically, she's still getting rid of, right, in other words, and this is totally controlled death because it's controlled by a gland. They call it like the optic gland, which is similar to the pituitary gland. Turns out if you remove the optic gland, she stops doing that. She stops breeding, and she also starts eating. She just walks away. She doesn't do that. It's a totally programmed thing that causes her to starve to death.
Wow.
But getting animals to starve to death isn't so good. It's difficult. If you want animals to die, the easiest way to have them die is to just put in a time bomb in their genetic makeup that goes off at a certain time. Similar to, so like aging, you can think of it as like a programmed genetic event like puberty or menopause. At a certain time, this little time bomb goes off and animals start deteriorating. This is just characteristic of mammals, but also of birds. So they start deteriorating. In the animal world, it didn't take much deterioration to cause you to die. All you had to do is be one step slower, and you wouldn't be able to get away or catch your prey. So it only took a little bit of deterioration. But the process was, it was a self-feeding process. Once it sort of like started, it continued getting sort of like worse. In other words, probably because it was developing more senescent cells was part of the whole sort of like process, and they would accelerate the process. So once it was starting, it was an ongoing process. And so the other way that people looked at it and did understand it is, well, how can any of these genes ever sort of like be developed? Because the animal that has them is not good for them. In other words, it's causing that animal to die. So how could it ever be? So it's impossible to be inherited because it's causing that animal to die. So, regardless of what it's doing for like, but that's sort of like missing the point. You can sort of like understand this if you sort of like look at the point of view and look at biologic organisms as like two parts. They have a disposable vehicle and they have an immortal genetic code. The program is to promote your immortal genetic code. Therefore, dying can now, once you have a whole lot of sort of like, so it's for, not for you, it's for your immortal genetic code that is spread in all your descendants. And you can see this if you look at a country. You look at, say, a small homogeneous country, 1 billion people. Well, say, everybody in the country, if you go back a couple hundred years, almost everyone's related to each other. Mm-hmm. So everybody is carrying the same genes. Now, if there's sort of like an invader, people who give up their life to repel the invader, well, they're dying, but they're promoting, but they're promoting their genes, because their genes are spread over like the whole billion other people in the country. So that's sort of like, so like they're and you can see a trait like bravery is essential. If you have a country and everybody has courage, your country's not going to survive. You have to have that sort of like trait. But the trait makes sense in a biologic sense. They're promoting their own genes. It's just they're not promoting, it's like they're simply promoting the genes of all their brothers and sisters and cousins, you know, which makes up the entire population. So that's the idea of like how like death is sort of like good for you in the sense of it promotes your own genes. And that's so if you think of this in terms of thousands of generations and huge numbers and computer programs, a computer program can show, yeah, this works out real nicely. You know, a computer program should show why it works. Well, why this was so important is that the people who said that you could never have genes promote aging because aging had no adaptive value, then they went into a real rabbit hole. Then they said, well, aging is different than everything else in biology. It's not controlled by genes. Well, aging is just then like controlled by the physical and chemical forces that control inanimate objects. Aging is really just like deterioration in an old car or an old shoe. It's just wearing out. It's just like that. It's just like wearing out, and it's really just the same as an inanimate object. Animals are just built to last a long time, and then they just wear out. It's, in other words, it's not a process it's not an active process being promoted by any genes. Well, that caused them to have a totally wrong concept of what aging was. Once you think of sort of like aging as a process that's being promoted by genes, genes have pathways. They have targets. They have sort of like now, from a biochemical point of view, it's real simple. You just find the thing that's promoting aging. You just find the sort of like chemical pathways, or biology, like in other words, the enzyme pathways that are promoting it. You just turn that down, then you're treating aging. And it turned out, so that was the sort of like idea. It turned out that mTOR was the thing doing it, which made mTOR sort of like quite remarkable in that it had been conserved for like 2 billion years. And over this time, it seems like it kept on getting a bigger and bigger portfolio. Initially, in the one cell, sort of like in a one cell organism, it has a very simple portfolio. It tells the cell, grow or don't grow. That's all. That was very important. You're like a one cell animal. You want to know, should I try to grow or should I not grow? If you sort of like, if there's a lot of nutrients, then you could grow. if you try to grow and there's any nutrients, then you're just going to be too small and die. So you want to know, it's like starting a business. You don't want to expand your business if you don't have a lot of resources. So it was just that. The telecells grow or don't grow. Then it's sort of like got a bigger portfolio, promoting growth. So now in young animals, it was like great. It was promoting growth and development, making animals big and fast and strong. So now in young animals, mTOR is fantastic. It was making, it was building muscle and bones and making them grow big and strong. But then in mammals, it got another portfolio. In older animals, it turned out if you simply turned on it up, you could accelerate aging. You could accelerate aging by increasing sort of like inflammation. You could increase the inflammatory pathways by turning them up, and that would sort of like promote all the age-related things. So like mTOR got involved in all the age-related diseases and aging itself. So it turns out that turning down mTOR gets involved in seems to be is real helpful for the great majority of aging-related diseases and helpful for just normal decline of aging. Mm-hmm. That's sort of but in order to understand that, you had to have a better understanding of that aging was a controlled process.
Right.
It was under control, which made complete sense because you can see how universal it is. It's not a random thing that's going on. It's like all people deteriorate. You can just look at people and you can see, okay, they look like they're 20, they look like they're 40, they look like they're 60, they look like they're 80. You can just look at somebody and see, I see what's going on. It's just it's not, random of different people. It's so universal. People can immediately spot, they can figure out people's ages within 5 or 10 years real easily.
See, yeah, I agree 100%. And it seems that the mTOR being a critical process, a critical mediator in the aging process. And so by getting out in front of it, like you said, and so weaving back to mTOR and using rapamycin as a...
Yeah, before I should mention, the person who came up with the idea that mTOR was driving aging, that aging and age-related diseases was just different parts of the same thing, and that was all being driven by mTOR, and it could slow down aging if you blocked mTOR with rapamycin, was Mikhail Blagoskalony. So that was sort of the extraordinary contribution that he made to understanding aging. The idea that mTOR was driving everything, that mTOR is driving aging, and that slowing down mTOR with rapamycin would slow down aging.
Amazing. How you prescribe this clinically, ideally you would like to start prescribing this maybe for ApoE4 carriers for patients in their 40s or 50s, or?
It seems to work perfectly fine if people are taking it before they have a deterioration. Mm-hmm. But ideally, I would think 40. If I was ApoE4 positive, I start at 40. Mm-hmm. 40 seems because on PET scans, you can see that there's changes in the cerebral microvascular system in the 20 to 40 age group. Since that's going on in the 20 to 40 age group, it makes sense to start around 40. Mm-hmm. But nevertheless, people do very, very well as long as they're starting before they're having significant mental deterioration. It doesn't matter if they're starting at 50 or 60 or 65, they'll still do very, very well, as long as, in other words, right. The point is, severe mental deterioration is going to be irreversible, but it's very sort of helpful at any sort of stage while people are sort of good. It's sort of I say I have 400 people with E4 positive. I haven't noticed any of them having any decline any more than anyone else. They all seem to be doing perfectly fine. And the sort of preclinical studies was very reassuring because they could make transgenic mice. They could make the mice ApoE4, and they could show that it stopped the disease process in the mice.
That's amazing. Now the dosing, is it considered off-label? Because obviously, you know.
Oh yeah, it's of course off-label. The only thing it's approved for is transplant medicine, but it's also approved for a few metastatic cancers, like maybe kidney cancer, and like real high doses. But basically, it's like totally off-label because the only sort of like thing it's approved for is transplant medicine. And in transplant medicine, it was approved to be used once a day. That makes it tricky also, because in anti-aging, you want to use it once a week. So that's sort of like tricky. As people look at it, say, well, it's approved to be used once a day. How can we use it once a week? Well, just like, so, I mean, but the idea of like once a day or once a week gets down to mTOR1 and mTOR2. So in like about 2009, 2010, 2011, they were like, it was very, very confusing because laboratory animals were doing better. In other words, they could show that you could increase the lifespan of laboratory animals in a 2009 study by like 10%, and a 2014 study by like 25%. So you can increase the lifespan of mice by like 25% with rapamycin. And it could be slowing down these like all these like age-related diseases in like clinical models. On the other hand, when they looked at sort of like its use in transplant patients, they didn't have any benefit. So it's like, well, if it's such a great drug, the transplant patients, they're not having any benefit. What's the idea? And then around 2013, like someone like, you know, like Lamin, he was like the scientist, he came up with pointed out that mTOR1 was providing the benefits. mTOR2 was causing the side effects. In order to have an effective treatment, you had to have a way to reduce mTOR1 and not mTOR2. Well, then they sort of like, so the idea is like, well, we'll have to have a new drug that just reduces mTOR1, but it didn't take that. It turned out that mTOR2 is completely resistant. mTOR1 is very sensitive. The half-life of rapamycin is 65 hours. When you take it every day, it's sort of like you build up the blood level, so you have a continuous high blood level. The problem was your body couldn't put together the little parts that made mTOR2 in the presence of a high blood level of rapamycin. Rapamycin just competed with all the little parts that it went to, so you couldn't have a functional level of mTOR2. On the other hand, if you took it once a week, you'd have a high level at the beginning of the week, knock down mTOR1. By the end of the week, you'd have down to like 5 or 10% levels. It wouldn't be enough to interfere and compete with mTOR2. So, because it was just a matter of like competing with all the things. So it's like a very low level of mTOR2. Your body could assemble mTOR2 and maintain a functional level of mTOR2, but have the benefits of reducing mTOR1. So that way it turned out that taking it once a week was like a way to reduce mTOR1 and not mTOR2. Then you didn't sort of like have the different like side effects of reducing mTOR2. You just had the side effects of reducing mTOR1. Reducing mTOR1 had very, very few side effects. It didn't have any really off-target side effects. Its only real side effect was reducing the activity of what's called the innate immune system. So you can have like the immune system. When you talk about the immune system, there's two parts. There's the innate immune system and there's the acquired immune system. The acquired immune system is what people usually think of. That's T cells and B cells, and it's called acquired because you acquire immunity. As you're exposed to measles, you acquire immunity to measles, you never get measles again. So it's acquired, but it's like T cells and B cells. Then you have the innate immune system. That's like, so the acquired immune system, that's the smart system. Then you have the innate immune system. That's not the smart system. They go by pattern recognition. And basically, to the innate immune system, anytime you have an altered molecule, they think it's a bacteria. So in their pattern recognition, anything that's peculiar, they think it's a bacteria, they start inflammatory process. So if you have molecules being changed with like aging, like they're oxidized or this or that, it sets up a chronic inflammatory process. So it turns out that like decreasing the innate immune system is very, very good for stopping chronic inflammation, very, very good for stopping all the age-related diseases. Mm-hmm. However, the innate immune system is your first line of defense against bacterial infections. And so it's not good for a bacterial infection or a fungus infection or an amoebic infection. They're things that sort of like require the activity of the innate immune system. Bacterial infections being the most sort of like important. So I give my patients, it's like they're all aware that they could have increased susceptibility to a bacterial infection. They have an antibiotic on hand, like zithromycin. And it turns out that if you take zithromycin in the first couple of hours of a bacterial infection, you're usually better within a couple of hours. As soon as you get a blood level, as soon as you get a good blood, so like zithromycin works, take 2 tablets. As soon as you have a good blood level, I mean, you're nearly knocked out the bacteria. So you don't have to take it for like one day. Generally, if you take it at like 6 o'clock before you go to sleep, you'll be feeling better. So as long as people know that, don't continue taking rapamycin when you have an ongoing bacterial infection. Take rapamycin. Because the idea that rapamycin, you say you took rapamycin on Sunday, you got a sore throat or earache or a cough on like Monday, you don't want to, your resistance would be lower. Mm-hmm. You don't want to wait till like the following Sunday for like your resistance to say back up to full strength. It's easy to just knock it out. As you said in that, but the antibiotic is so powerful, it doesn't matter if your innate immune system is a little below par. The antibiotic just like knocks it out. So you like get better right away.
That's a good point, but I do want to emphasize the importance of calming down the background innate immune system activation. A lot of people I think are unaware about this, what's known as inflammaging in the research. That as you age,
what they're calling inflammation is exactly what I'm calling what I'm sort of referring to. Mm-hmm. That's the sort of like what's being driven by the innate immune system. So anytime Turner is talking about inflammation or like inflammatory, so that's sort of like term they're using. I just don't like the sort of like, like the term I sort of use. It's like, I just use chronic inflammation. But what they're talking that's exactly what I'm talking about. That's something that's being driven by the innate immune system. Turning down the innate immune system is stopping that entire process. Mm-hmm. That is the two sort of like things that that's like most commonly involved in that people notice is number one, gingivitis. Gingivitis is this chronic inflammation which has been stimulated by the bacteria, but the bacteria are not invasive. They're just maybe looking like bacteria, or maybe they're making new chemicals. At any rate, they're sort of like promoting chronic inflammation. The chronic inflammation they're promoting is then promoting sort of like gingivitis, formation of plaque, like gum disease, dissolving the underlying bone, all the severe, periodontal disease. Coronary disease is the same process. And in coronary disease, it's just like there's a different trigger. It's triggered by cholesterol. The LDL cholesterol has got oxidized. Now it looks a little peculiar. It looks a little peculiar to the innate immune system. They think this looks like bacteria. They start the same inflammatory process, building up the same kind of plaque and calcification. And that's sort of looking like eventually occlude the arteries. That's the same sort of coronary disease. It's the same, very similar disease process. Now, it's not like gingivitis is causing coronary disease. It's that they're both having the same fundamental chronic inflammatory mechanism that's sort of promoting the sort of disease. So it turns out that lowering cholesterol is good, but simply rapamycin is extremely good for stopping coronary disease. Because basically, coronary disease is not something I see in my patients. It's like rapamycin. It's stops that disease. It's remarkably, because it's stopping the chronic inflammatory process. And they've showed that with animal studies very well, how it's is stopping that process. And they have showed how the process was inflammation, it was senescent cells, there was a whole that was starting, it's being triggered by the cholesterol. So that's the initiating thing. But the process itself is chronic inflammation.
Mm-hmm. Fascinating stuff, Alan. Now, is there a weight-based dose regime? A 200-pound person, would they take less of a rapamycin?
I just do it empirically. Mm-hmm. Well, certainly, 6 milligrams is a generally standard dose. But if somebody is 120 pounds, some woman is very healthy, 120 pounds, I start 2 milligrams. And it's somebody but if somebody is and it depends on this thing. If somebody is E4 positive, I'm more inclined to have a higher dose, more 6 milligrams. But people can get used to the dose, and so you can increase it after people have been on it for 6 months or so. You don't want to start a high dose and people right away, because they're more likely to have what's called aphistobatitis or canker sores. That's dose related. People tend to get that sometimes in the first 3 to 6 months. Not everybody, some people. But the higher the dose you have, the more likely you are to get it. So it's better. In other words, so if you jumped in with a real high dose, you might be more likely to get that, those sores, which are kind of trivial to pinpoint little spots that hurt for a couple of days. But still, it's better to start off on a lower dose. A lower dose of 6 milligrams seems to work very, very well in most survey people.
Mm-hmm. And have you noticed any compromise in athletic performance or sports recovery or things like that shortly after taking it? You mentioned the blood levels, it has a half-life, you said 60 hours.
Rapamycin is very good for sports performance because it's very good for age-associated decline in cardiac function. In other words, you see runners after 30, if you're looking at Olympic runners, there's marathon runners, having a progressive decline from world records just about 2 hours to 3 hours to 6 hours to 9 hours at 190 years old. If you can finish it at a marathon in 12 hours, you're doing great. This is the heart. In other words, this is characteristic of everything with the heart. All animals with the heart have an age-associated decline in heart function. That's the reason why you in other words, that's the decline in maximum performance, and you can see it in runners. or you can see like, so forth. Rapamycin is real good for that. That's what sort of like the studies that like Matt Cable was doing in dogs. He was showing that in healthy older dogs, rapamycin was improving their heart function. And he could show that in the echocardiogram. And then the same sort of like somebody else at the same institution was showing the same thing on mice. And on mice, they could show exactly how it was happening. It was related to a change in kind of like fuel. It's like there was a shift in what the mitochondria was burning. They were burning, like in older people, they were burning like low-grade fuel. And in younger people, they were burning more like a high-octane fuel. And rapamycin was sort of like shifting that back to sort of like the kind of high-grade fuel they were burning in younger people. And they could see that when they sort of like had like what would be called like a proteome, and like they mapped the entire protein picture, and they could see that the proteins involved in mitochondria were the things that were changing. They were sort of like changing from one to another. Rapamycin was like shifting that, and that was sort of, and so, yeah, I generally like people who are sort of like very attuned to that, like cyclists, frequently notice that on rapamycin, all of a sudden, they have better cardiac performance. They can cycle faster. They have a higher heart rate. Their maximum heart rate is better. Their cycling speed is better. So it improves athletic performance.
Wow.
And a lot of my patients are sort of like, they're like the top performers in sort of like, they're like senior Olympic type of events. In other words, they're being so fit, they're sort of like, in other words, it improves, they have better performance. One of my patients came in, is sort of like, well, sort of like, second in, like these world events, like, running and sort of cycling. So it improves performance in older people.
That's impressive. I think the perception is that by way of reducing mTOR, you're decreasing muscle protein synthesis, so therefore it would conflict with exercise. But
that's sort of like confusing what happens in young people with what happens in old people. In young people, mTOR is of extreme importance in building strong muscles. You're a teenager, mTOR is the thing that's making you fantastically strong. It's building muscle. But that's not what's going on in old people. In old people, they stay strong by maintaining the health of their muscles. So if you, like rapamycin, helps you maintain the strength of the muscles, retain the quality of the muscles, maybe maintaining the sort of like mitochondrial sort of like function of the muscles, it's helping to maintain, it's not building new muscles, it's helping to maintain healthy muscles. So like people are doing sort of like real well. It's not something for building new muscle, it's for maintaining function of the muscles you have.
I love that. That's beautifully articulated. Really, I think that this podcast, this discussion will help a lot of people better conceptualize mTOR inhibition as an age.
Yeah, if you wanted to sort of like be a bodybuilder, rapamycin would be the worst thing in the world for you. It's not going to, it's going to sort of like totally block your ability to build up big muscles. On the other hand, if you just wanted to be a fast runner, rapamycin would be real good for you.
Well, speaking of bodybuilders, their life expectancy is not exceedingly long, so they're not a good...
Yeah, well, the problem is like the extent that they're building up, that the extent that they're doing things that increase mTOR, that shortens. You can see that in sort of like very, very muscular dogs. Like it's sort of like, and you expect a very muscular dog to have high levels of mTOR, high levels of like growth hormone, and they have like a Mastiff, maybe like, a Great Dane, a 7-year life expectancy. On the other hand, medium-sized dogs is 12 or 13. A Chihuahua is like 20 years.
Yeah.
So you can see within the sort of like, like same species, the sort of like the smaller animals, or like the animals that don't have the massive musculature, have a longer lifespan. You know what I mean? You just basically just look at like whether you want to be a Chihuahua or whether you want to be a Great Dane.
I think a lot of people mentally struggle with this, myself included, because you hear and there's a lot of research to show grip strength is so important, and having strong legs is important as you get older to get up.
I think rapamycin is good for grip strength. I mean, in other words, I would say it's like rapamycin, like sure, grip strength is very, very important. It's an indication of good health because it shows, in other words, grip strength is mitochondrial function. In other words, it's like, in other words, how well muscles are functioning, how much well the mitochondrial function, and that's real important. Grip strength is certainly a very, very good indication of sort of like good health. Rapamycin is not impairing grip strength.
Yeah.
You know,
I love it. Alan, I'm sure we could talk for hours about all things science, aging, longevity, rapamycin. I'll put links to your website below. And you're seeing new patients. You work with a lot of people. They have to come see you in person for the first visit.
That's the idea. The idea is I'm licensed to practice medicine in New York. I can't project myself electronically into Kansas. I'm not licensed in Kansas. So like that's the idea. People have to come to New York for the initial visit. And I can generally follow them after I've seen them, but people have to come to New York for the initial visit.
Good. That's amazing. So what's new for you on the horizon in terms of what do you do for your exercise? Are you a walker? Do you like to run?
I like to sort of like walk. It's like, but basically I like sticking in there. I have all my own sort of like issues related to that I didn't start treating my cardiac problem 10 or 20 years sooner. But I like sticking in there.
Good for you, Alan.
But I'm not certainly doing as well as my healthy patients who are just sort of like mind-blowing how well they are doing.
Wow. So that's what keeps you inspired, working with these people. You're just continually inspired by your own patients.
Yeah, absolutely. I just like talk to people and like everyone, like, you know, there's talk to people like, you know, a year later and they're saying, "Oh, how you doing?" I'm just like, "Oh, I'm doing great. I'm doing great." Just like, you know, I just want to refill because I'm doing really great. It's like I didn't have it. What happened? Nothing happened. I didn't get sick. You know, like in other words, so everything like worked out. It's like, yeah, it's very sort of like inspiring to see how well people are doing.
That's amazing. Alan, really appreciate you coming on the show and sharing your wisdom and helping everyone to conceptualize aging and longevity, and keep up the great work.
Thank you. Yes, it's very, very important to understand it, but you can see it's very special in that it's being introduced from the ground up. In other words, most medical things is like big pharma introduces a drug and it's like the institutions. No institutions are using rapamycin because they never use off-label things. The entire steroid stuff is coming from the ground up. It's coming from people who are studying this stuff online and podcasts and sort of like all the sort of like information they can get on the internet, listening to sort of like very good podcasts, seeing that, and other individual doctors introducing it into their practice. Like not to, so this is sort of like, you know, a very much grassroots, ground up process being sort of like stimulated by people, by like patients who are saying, like that looks very good, I want that. And it's basically people who are extraordinarily smart and very, very good at analyzing data.
I love these grassroots movements. I mean, this is like I think there will be KISH reports and then maybe a randomized clinical trial at some point.
Yeah, right. It's things like that. But you can sort of like, in other words, you could do real cheap things like a questionnaire, like what Matt Kablin did, a questionnaire of how are you doing, and people saying I'm doing great, you know, and things like that. But you can't do any sort of like, there's not the money to do, you know, big, you know, double-blind studies.
Yeah. Amazing. All right.
Okay,
appreciate
it
you
was
coming
great
on.
seeing you, Mike.
You too.